Morning, good afternoon, and good evening. Welcome to the 1369th day of continuous and uninterrupted Zoom session of IFPH. Let us start today's program with a silent prayer for 1 minute. Thank you. Welcome back. Today we have with us Professor Dr. AJAYAN.MD, HOD, Department of Practice of Medicine, Sardarshana Homeopathy Medical College, Pulasekara, Tamil Nadu, India. National level faculty of IHK, that is Institution of Homeopathy, Kerala. Winner of Dr. AJAYAN Award, more than 25 years experience. The subject is MONSOON epidemics, role of stage judgment in clinical practice. Quite interesting, as always. Dr. AJAYAN is always thinking in different ways, so that is able to present all these topics. He's one of the instrumental persons in developing the Sardarshana Homeopathy Medical College, the double engine homeopathy medical college in India. Dr. AJAYAN, please proceed. You can have the platform for next 45 minutes. It's over to you.
Okay. Just I share my PowerPoint.
Yes, you can.
Okay, is an audible, sir? Is an audible?
Yes.
Okay, just good evening to all. First of all, let me express my sincere thanks to our organizers, IFPH. Again, give me a platform. Then today our topic is relevant for this time. Is a monsoon epidemics. The like other classes, the previous classes, then I would like to highlight the homeopathy part, the role of stage judgment in clinical practice. Then always in previous classes, I will try to convey with you the importance of stage-wise diagnosis in homeopathic science. Because we are believing symptomatology, each and every disease, its own different stages is there. In each stage, their symptom and sign is entirely different. That means the symptom and sign is change. That definitely the medicine also change. Then always we are remember the homeopaths need the 3 levels of diagnosis for homeopathic prescription. The right homeopathic prescription, first one is anatomical diagnosis, and second one is pathological diagnosis, and third one is clinical diagnosis. The 3 levels our diagnosis is right, we can able to prescribe right homeopathic medicine. Normally in monsoon disease is a common disease. Everybody aware, everybody know these are the common diseases. But this class is helpful just to refresh our knowledge. That's all. Because the last few months is a very heavy temperature. Then now the last 2 weeks onwards, the rain is started. We are again here for the monsoon. Within short period, we are starting the monsoon. The rainy season we are started. But these are the diseases common. But the recently in our Kerala, the hepatitis A, then other the cholera, then certain these type of diseases, infectious diseases is recently reported, especially hepatitis A. But in my practice, I am around 30 years clinical experience, the professional experience. In this the 30 years, then the beginning, the 2008, I remember 2008, and that period, around 5 years, in my practice, at least per month, average 60 to 70 cases of hepatitis A cases are reported. But the last 10 years, the hepatitis A cases is very less. The number is very less. But recently, through the newspapers, then our Kerala, then few cases are reported. Then sporadically, they are spreading the few hepatitis A cases reported. The common monsoon diseases are hepatitis A, then dengue fever, influenza, malaria, cholera, etc. Then another few diseases in recent years, the previous years, is one of the condition, one of the disease, the prevailing infectious diseases is there. One is the scrub or typhus, scrub typhus, and you have heard about the monkeypox, then hand, foot, mouth, and diseases. So commonly we are seeing hand, foot, mouth disease. Then monsoon, regarding the monsoon epidemic, the analysis revealed the rate of incidence of infectious diseases on rise in every year, especially monsoon. Every monsoon, then hospital sees 25% rise in the number of patients. The common reasons for these monsoon epidemics are unhygienic eating habits, such as eating out often, not washing vegetables and fruits before eating, drinking unsafe water, and then leading to rising number of cases of the gastroenteritis, jaundice, typhoid, etc. There is this class, my aim to gain the knowledge about the common monsoon disease. I have already discussed with you, and is homeopathic management. To know about the different stages and development of monsoon disease, the importance of stage, understanding of the different stage of diseases in clinical practice, we are already discussed with you, already conveyed with you. To understand the variation in the homeopathic approach of dealing different stages of disease. What is stage of judgment? The disease staging is clinically based severity measurement that uses the medical criteria to assess the stage of disease progression. We are homeopaths. We are used this stage-wise diagnosis for the therapeutic purpose, but at the same time, the stage-wise diagnosis knowledge is helpful to work out the prognosis of the disease. That is very, very important. For the best example, the hemorrhagic shock is happen in dengue fever. The suppose that stage and related symptom and sign we are aware, maybe with the help of homeopathy medicine and the general management, in advance that knowledge help for the manage that situation. So sometimes we are not able to manage the case. This knowledge, the stage-wise knowledge, is helpful to the refer the cases for the higher centers. Then availability help in hospital, reimbursements and management. Stage judgment is an essential part of the homeopathic clinical practice. Then the nowadays the stage-wise diagnosis, then another role is in related to then our reimbursement. Here the reimbursement I am highlighting the nowadays the patients are using the different policies, the health policies. Then health policies, their first time they are asking about how many days treatment is needed. That time you are right to the this and concerned authorities. Therefore, that time the stage-wise knowledge, the stage-wise disease knowledge, very useful for us to convey this matter to the authorities. Then fourth point, the judgment is help to patient aspect to assess patient current illness states and general management. Medicine aspect to choose a medicine matching the peculiar nature of the patient in that stage. That means the stage-wise judgment is helpful in different level. So now in taking a case, we must take into consideration the nature of the disease and its peculiar type. We must know disease accurately before we can give effective relief. The simillimum is practically never found among the diagnostic symptom. In considering the diagnostic symptom in the selection of the remedy, its only practical value is in excluding those remedies from consideration which do not correspond to the genus of disease, but act chiefly on other part of the organism. These are the comments related to the great Star Wars H.A. Robert in Principles and Art of Cure by Homeopathy. Currently, the prevalent disease, first we are discussing this, and second that in Kerala, the recently reported, not recently, the previous year, is in scrub typhus and monkeypox. It's also called bush fever. It's an Suspamushi disease. It's otherwise called it as Suspamushi disease in an acute febrile. Suspa is a Japanese word from their meaning. Is a bug. Is a Japanese word. The both Japanese word. It's a dangerous bug. Susgamushi. This antibacterial infection is caused by gram-negative obligate intracellular. Epidemiology globally, over 1 million people are at risk for the scrub typhus, and as estimated 1 million cases occurs annually. The scrub typhus appears particularly distributed in Susgamushi triangle, that is including is in our triangle include Susgamushi triangle in China, Australia. In our country also included India and Pakistan. These are the common areas we are seeing in Susgamushi disease. That is called Susgamushi triangle. The epidemiology shows. In India, commonly affected states are Jammu and Kashmir, Himachal Pradesh, Uttaranchal, West Bengal, Assam, Maharashtra, Kerala, and Tamil Nadu. These are the common states and they are seen is Susgamushi disease. The peak incident we are seen in September to November. That means in our clinical practice, suppose this particular wet climate, the cases are, we are discussing their related clinical signs and symptoms. That signs and symptoms are there. It's supposed to be the September and November. We are carefully consider this one. The past outbreak in India, Assam and West Bengal, during World War in Himachal Pradesh and Sikkim, Darjeeling during 2003 and 4. Then here the transmission, the bites of infected chiggers and tropiculoid mites. These are the maintaining and incident host. There is an after the bite is reached to infective stage, that is the larvae. This only stage can transmit the disease. In alpha form, it can transmit the disease. It's an mode of the transmission. Then accidental exposure to the larval mite while walking is either sitting or lying on the infected ground. Is a mode of spread in infection. Rather than biting or the piercing the skin, the mite larvae prefer to insert their mouthpart down the hair follicle or pore. Normally, their incubation period is 6 to 21 days. On average, the incubation period is 10 to 12 days. The large number of bacteria, the present in the salivary gland of these larvae, they injected into the host. That is a normal spread of the organism. Then here the pathogenesis and pathology is very important. After incubation, this larvae, then first it will produce ulcer. That is called it as scar. The scar, then biting area, inoculated area, there is an ulcer is formed. Then after inoculation, invert the local lymph node, then associated the lymphadenopathy of the local lymph node. Then again is spread to by the bloodstream, spread by the bloodstream. It's a general symptom, fever and malaise. They invert the vascular endothelium vasculitis, and later, very beginning, the local lymph nodes are enlarged. That means the scar formed in a particular site and related lymph nodes are enlarged. But later, there is a spread through the bloodstream, is spread to all over the area, is an invert the vascular endothelium. It will produce vasculitis and general lymphadenopathy. Then first sign in clinical features, the first sign we are already discussed is an eschar. The eschar is the form at the site of the larval, inoculated site. That is look like is a cigarette butt. It's a pathognomic feature. Therefore, is an clinical side. The clinical will help for the clinical diagnosis. The appearance wise, the ulcer appearance wise, we are diagnosed is a cigarette burn like look like ulcer. There is a central part is the black necrotic center with the erythematic border. But there, just you consider one more condition related to pyoderma is a ecthyma. Ecthyma again is a light black crust, but the one of the feature in differential diagnosis we must consider ecthyma, pyoderma ecthyma. There is a black crust, but the differentiating point is while removing this black crust, we are seen in then ulcer, we are seen, or at dermis and epidermis, we are looked the lack of pus in a saucer. That is a deep-seated pyoderma. Actually, ecthyma is a superficial and as well as deep-seated pyoderma. Therefore, there is a differential diagnosis that just to consider ecthyma. The clinical features week 1, there is an eschar formation, the fever and malaise, severe headache, and myalgia, conjunctivitis. These are the common symptoms. End of the week, the maculopapular rash. There is a stage of this particular disease of fever. Then week 2, then systemic affection. There is central nervous system, respiratory system, and renal GAT, and related system-related signs are there or symptoms. The symptom fever, malaise, severe headache, myalgia, and conjunctivitis. There is a maculopapular rashes that start from the trunk and spread to the limb. That is centripetal. That is a presentation, centripetal. It is a maculopapular rash. The diagnostic criteria for this graph here is a serological is a mainstay. The method the presence of IgM antibody, and also we are seeing an IgG. The IgG normally increase at end of the second week, at the end of second week. But IgM antibody, we are seen in scrub IgM antibody. Here first we are seeing end of the first week, at end of the first week. But in reinfected cases, this IgG, this is second week, immunoglobulin G antibody titer appears in very earlier, in sixth day onwards, is an appear in the blood. Otherwise, in primary cases, IgM antibody is an end of the first week, and IgG. Therefore, you are remember, while advising your suspected cases, we are advised an investigation. These two tests, that these serological tests, IgM and IgG antibody titer value is very important one. Then IgM values and appear in primary, then first appearance cases in first end of the first week, but IgG antibody only at the end of the second week. But the reinfection cases, the both are appeared as earliest, very earlier is an appear in the blood in the sixth day. Then PCR polymer chain reaction, PCR test. The major advantages can detect before the appearance of the antibody, the PCR test is positive. That means the PCR is, that is then scrub typhus test. The PCR scrub typhus test, just to advise. Then it will help for the earlier diagnosis. It's a very high sensitive and specific test, but it will little bit is very expensive. Then wheel Felix test, another test is here. It's an old test. It is oldest, but it's still it is used, but it's a low sensitivity. But the PCR is highly sensitive test. But the wheel Felix test is a cost effective, but the PCR test is an expensive test. But in so many advantages is there. Very earlier diagnosis will help for early diagnosis of the scrub typhus fever. The prevention to avoid area with a lot of vegetation and brush, the wash hand and feet after the outdoor activity, avoid outdoor activity during the humid and rainy season, wear full sleeve clothes. These are the precautions. Then again, these bites, the chigger bite is helpful to prevent the percutaneous against the chigger bite and scrub typhus. Then very beginning, I say is transmitted through the bites of the chiggers, especially when you are playing outdoor and taking a stroll in a park, maybe the chance for the infection. The vaccination is there. In homeopathy management, then if an insect bites, then remedial in stage wise, the common drug we are used and Ledampal and Apis mellifica. Then Eschar is in first stage, then is black necrotic center with erythematous border. We think over the arsenic albumedrona and MONSOON. But the late stage in second week, that is maculopapular, is centripetal in appearance. You think about the aconite, ammonium carbonicum, belladonna bryonia, dulcamara, and silicium. The next condition we are discussing is monkeypox. So pox, then almost is similar to our smallpox. Is a zoonotic orthopox virus that accidentally causes disease in human, almost similar to 95% is similar to smallpox with notably low mortality. It's a monkeypox virus, a family pox virus. A genus is an orthopox virus. The features of virus, brick shape and lipoprotein, but the envelope is in lipoprotein. It's a double-stranded DNA genome. There is a character of these viruses. The first isolated and identified in 1958 from monkeys when shipped from Singapore to Denmark, research facilities fell ill. The first time is an identify. The history shows this one. The first confirmed human case in 1970 at Congo. As an already I say, is a zoonotic disease endemic to Central and Western Africa and Congo. Other natural reservoirs include, everybody know, there's squirrels, there's rat, mice, human. These are the other natural reservoirs for the infection. Then spreading is, and just you aware about it, it will help for the prevention of this disease. The primarily is an affected animals are typically rodents, is an bites and spreads, or the consumption of the bush meat. The human to human transmission is the primarily animal that typically is spread to rodents. And one more spread is there is monkeypox by human to human transmission is possible, but it's very limited. But through the close contact with infected respiratory tract secretions or the skin lesion, there is a two ways of the spread of this infection. The symptom: intense headache, fever, swollen lymph node. The scrub fever, we are discussing the lymph node enlargement. Then very first, there is regional lymph node, then followed, then all over the body, then spread to generalized lymphadenopathy. But here the regional lymph node enlargement, the backache, chill and exhaustion, then the muscle pain, severe muscle pain. The illness is last for is in 2 to 3 weeks. Is an replicate the at the site of inoculation, spread to lymph node, initial viremia, viral spread, seeding of other organs. The normally is an incubation period is 7 to 14 days. Then secondary viremia, the symptoms start to appear. Then here, the very first the symptoms are appear on the face. That is 95% of cases. Then very first the symptoms appear on the face. Then palms and face, the palms, both hands. That is 75% of cases. Then it is 30% of cases and shoulders 75% of cases. There is a nature of the rash tends to the first develops on the face. Already discussed. The again is spreading elsewhere in the body. There is a percentage of appearance of the rashes is respectively 95% face, palm 75, genitals 30, and shoulders 75%. These are then affected the systemic organs, back pain, muscle ache, intense headache, low energy, swollen. That means the constitutional symptoms are relevant. Then clinical features, within 1 to 2 days, the predominant symptoms are fever greater than 38.5 degree, myalgia, fatigue, lymphadenopathy, headache. Then fever subsides, the rashes are appearing. The like our everybody know the chickenpox and other pox families and related. Even the constitutional symptoms, suppose especially the fever is subside, that time the rashes appear. The rash progression up to 2 days, up to 4 weeks. Isn't here the rashes appearance centrifugally? That is in our smallpox as also centrifugally, but chickenpox centripetally. Centrifugally concentrated, total number of lesions few to thousands. Then again, few individual associated with the mucosal lesion in mouth, followed by skin lesion, face, extremities, including palms and shoulders. Then here the very first the rashes are macular, like other pox conditions, macular, papular, vesicular, then pustular. Over the 2 to 4 weeks, the lesion involved and they increment. That is the macular, very first that is the macular rash, and later is tends to pustular. The lesion chain progressively form deep-seated 2 to 10 millimeter. The size, even a single pox, the size is exceeding up to 10 millimeter. In pustular phase, it remains the around 5 to 7 days. Then after that is crust formation. Then later is estimated over subsequent to 7 to 14 days. The condition resolved around 3 to 4 weeks after the symptom onset. The patient is not infectious after all crust fallen off. Then maybe that is an infectious to spread to others, even the crust is and fallen off. But the intensity is less. But the complete the crust fallen off, there is no any chance of the spreading of infection to another person. Investigation, like other pox diseases, there is a illness protocol. Here, like other pox diseases, we are using the pustular rash illness protocol. That protocol also here we are use. Then CBDC, not CDC. Then viral isolation in viral culture. Then earlier diagnosis and PCR polymer chain reaction from the monkeypox DNA. There is a World Health Organization suggested there is a protocol. This is a protocol is used for the treatment. This is normally that is called it as generalized vesicular or pustular rash illness. The Institute of Airborne and Contact Precaution, Alert Infection Control on Admission. This protocol is normally used. Then here the three categories are there: low risk of smallpox, that is a moderate risk, and high risk group. There is an history and related protocol wise your diagnosis and advise the treatment. Then risk of the smallpox, high risk of smallpox, febrile predoms, and classical smallpox lesion, and lesion in some stages of development. Then major criteria include is in febrile prodromes, so greater than 1 degree Fahrenheit, is a last for 1 to 4 days. Then classical pox lesion, deep-seated form, hard and round circumscribed vesicles. Then the lesion in same stages of development on any one part of the body, all the lesion in same stages of the development. I am not going to the details of the protocol. This protocol is available in our net, but this protocol is followed and we are able to treat the case. Then WHO protocol, suspected cases, probable cases, confirmed cases, and discarded cases. But in suspected cases, these are the symptoms. Patient with any age, non-endemic country with an unexplained rash, one or more following symptom: headache, lymphadenopathy, pain, asthenia. There is a suspected cases. This is the probable cases. Is a recent update. The met suspected case criteria plus epidemiological link exposed to infected individual, then recent history of travel to monkeypox endemic country, and multiple sex partners. There is a probable cases. Next,
Yes, please restart the screen sharing, Dr. Jayan. Am I audible, Dr. Jayan? Am I audible?
audible. Sir, please wait. Okay, is then how the prevention of the monkeypox, then avoid physical contact. Sir, is an audible?
Yes.
Okay. Then avoid physical contact with infected individual and do not share personal items wear gloves and necessary personal protective equipment, wash hand regularly, cook all animal product well before consumption. Then wear gloves and protective clothes when approaching the sick animals. There is an homeopathy management. The medicine selection is based on symptom similarity. The common homeopathy medicine include belladonna, rustox, bryonia, arsenic album, dulcamara, and variolina. Belladonna, the heat of whole body with the bluish redness of whole surface, intense erysipelatous fever. The pustules on nape of the neck, arms, and back. Therefore, the belladonna first we have to think about that is a centrifugal. The skin scarlet and so smooth. That's an indication of belladonna. Rustox is a commonly used. The intolerable itching, pustule eruption, erysipelas inflammation, then eruption skin and turns livid. The scarlatina, malaria, rash, dark, fever, high drowsiness and restlessness. Bryonia, the red elevated rash-like eruption all over the body. The slow development of rash in eruptive, severe and sudden receding of rash with the difficult and inflammatory affection of the chest. When scarlatinous eruption delays or the sudden recedes, dropsy, pleuritis and meningitis, as an bryonia is indicated. Next, I would like to highlighting another I mentioned is hand, foot, and mouth disease. It's a commonly affected in infant and children. It's a mild but highly contagious viral infection common in young children. There is a term we are used HFMD, hand, foot, mouth, and disease. There is occurs mainly in children under the 10 years old, but can also occur in adults. It's a causative organism. The Coxsackie and A16 virus is the common cause involved in most cases, but illness is also associated with other strains. The enterovirus 71 has also caused outbreak of hand, foot, and mouth disease with associated neurologic involvement in the Western Pacific region. Speaking of nasal and throat discharge, saliva, fluid from blisters, contaminated surface, equipments, toys, etc. That means in a particular family, one child is suffering this disease and other also is a chance for get this infection. From contact with the skin lesion is a fecal-oral route, contaminated food, then untidy hands, etc. is a spread of this disease. Most contagious during first week of illness. And virus persists in stool for several weeks. It's a high-risk group, children in the nursery, those who are studying preschool, overcrowded area, unsanitary environment. Those people, those children is most commonly affected this HFMD. During the epidemic, the virus spread to child from the mother to fetus. The incubation period 3 to 6 days. Clinical symptoms, the fever, anorexia, and malaise. Then the common another one more symptom is frequent salivation. Then even the always care of our child food habits. The children are always this type of hand, foot, and mouth disease. They not eat well. They not take their regular food. That time only the mother is concentrated the oral mucosa. We are seeing ulcerations. It's a sore throat. Then 1 to 2 days, and after the onset of the painful sores may appear in the throat. Then mouth while looking is vesicles are there. The non-itchy vesicles on hand and foot, usually a self-limiting illness. Within short periods, it will disappear. Without treatment, it will subside spontaneously. Without treatment, it will subside spontaneously within 7 to 10 days. That's a normal recovery period. But right, homeopathic medicine we are selected, it will disappear within my personal practice, personal experience. It will disappear within 1 to 4 days. Even the very beginning, we are starting the treatment maximum, then 4 days. Within 4 days, all the lesions are disappear. It's a hand that is a virgin, the lips and tongue and oral is common. And the hand also, hand and foot also, the soul also, we are seeing the lesion. Treatment, no special treatment is available. Most cases do not require admission. It's a symptomatic treatment. In management, isolate the child, isolate the child and quarantine at home, because again while diagnosed, after the diagnosis, never the child is sent to our school. The please the quarantine. This quarantine measures is a help to the prevention of the disease from spread to one child to another one. That is therefore the proper guidance given advice to our parents. Then prevention, wash hands, disinfect the common areas, teach good hygiene, isolate the contagious person. These are the common measures.
Yes.
In homeopathic management, then very important drug is the vesicular eruption, eczema, then mucous membrane inflammation, then burning redness over the cutaneous surface. Everybody know the Rastox related symptoms. Then graphitis, ranunculus bulbosus. These are the common drugs used for the management of hand, foot and mouth disease. The next, one more condition we are discussing today is in dengue. It's an arthropod-borne infection. There are 3 different presentations we have seen in our clinical practice. Classical dengue fever, dengue hemorrhagic fever without shock, dengue hemorrhage with shock. These are the clinical presentations commonly we are related to our dengue fever. The past 3 decades, the dramatic global increase in the frequency of dengue fever. Then 50 million infections occur worldwide annually. Tamil Nadu and Kerala has the highest number of dengue cases. In 2017, then according to National Vector-Borne Disease Control Program, it's an outbreak is there during that period. In 2016, Tamil Nadu reported 5 dengue deaths. 2020, number is 52. But nowadays, it's a common disease. So not only this particular period we are seeing in dengue fever, irrespective of the season, we are able to diagnose the dengue fever. Then suppose in our value, the platelet count is reduced, the drastically reduced. In my personal experience, we are says like this. We are treat the fever is subside. Then after only the platelet count is decrease in the blood. Therefore, my request that even the clinically diagnosed dengue cases, we have check the platelet count, check the platelet count only after the subsiding the fever. That during the time of pyrexia, maybe the platelet count is normal, within normal limits. That is within 1.5, 1.5x. But the clinical symptoms are there, or right after a diagnosis of dengue fever, after subsiding the fever, once in 2 days, we are frequently check the platelet count. Because after the fever is improved, Therefore, we are neglecting the investigation, but the pattern count is drastically decreased in the blood. Therefore, a suspected case or a diagnosed case of dengue fever, even after studying the fever, regularly 3 or 4 times, regularly you have check the platelet count. Is a distribution of the case according to this month-wise distribution. August and September, the cases are reported. The more we are seeing more. The coming days, we are respected this dengue fever. Transmission, there are 4 viruses. The dengue virus 1 to 4. The dengue virus 4. The vector is, there are 2, Aedes albopictus and EGT are the vectors of the transmission of the disease. Aedes mosquito become infective by feeding on patient from the day before onset of the 5th day of the illness. After the intrinsic incubation period, that is 8 to 10 days, the mosquito become infective, and then it is able to transmit the infection from the vector to the next human. This circle shows the mosquito takes a blood meal from the human. Then extensive incubation, the virus infection of midgut infect the midgut and eventually travel to the salivary gland, usually 8 to 10 days. Then it is spread to human. There is a human infection. After biting the human infection, one mosquito can infect, then several humans. Then intrinsic incubation period, onset of the symptom usually takes place 4 to 7 days. The intrinsic incubation means inside the human body, not related to a vector. This is a pathogenesis, pathophysiology. That is, we are carefully study that pathophysiology. Then because they are the stage wise, it will help for the stage wise diagnosis. The stage wise diagnosis help for the in different level. It will help. What the first one is the selection of epidemics. Second one is to help for the prognosis of the disease. Can able to say the prognosis of the disease. After biting, the virus penetrate the skin. The virus infect and replicate inside the Langerhans cell. That is a Langerhans cell. That is the immunity of the skin. It can affect the immunity. Then this cell release interferon. Then it is infected and hence go to the lymphatic system to make the immune system. Then system alert, then it goes to the circulation, can causes viremia. That is in blood, the high level of the virus is there. Then activation of immune response. That due to the immune response, the increase the lymphocyte count. That time we have checked the blood, it will show the lymphocytic leukocytosis. Then simultaneously granulocytopenia, that is decreased neutrophil count, that is white blood cell. This is one of the component is a granulocyte, that is a lymphocytosis, leukocytic lymphocytosis. Then it is a release of the pathogen causes fever and increased blood pressure in the vessels, causes rashes, and the classical presentation of dengue. This is a pathophysiology of the dengue fever. That means then after the penetration is affecting the immune system, that is first affecting the Langerhans cells. There are 3 levels of presentation. One is subclinical, then dengue fever, the classical dengue hemorrhagic fever. It's very high. The high, that means then after affecting Langerhans cells, there is an interleukins and cytokines are released. The high production of the cytokines, that is the plasma derived chemical mediators are released. Then is large affected, that is in dengue hemorrhagic fever, but moderate the presentation is a dengue fever. The clinical presentation is dengue fever. After the mosquito bite, maybe less virulent virus strain can cause subclinical symptoms, low cytokine production. Therefore, 3 different level presentation after infection, either by a subclinical or classical dengue fever or high virulent, high level of production of cytokines, the different chemical mediators can cause dengue hemorrhagic fever.
Excuse me, Dr. Ajayan, only 5 to 6
Then
minutes.
symptomatic. Okay. Then a symptomatic infection, undifferentiated viral syndrome, dengue fever, dengue hemorrhagic fever. Then here we are listen, dengue hemorrhagic fever, there is a plasma leak syndrome, maybe the dengue shock syndrome. It will produce a dengue shock syndrome. All the hemorrhagic fever is not producing the shock syndrome. Maybe is no shock is developed. That is dengue hemorrhagic fever. Now the dengue hemorrhagic fever is not producing dengue shock syndrome. The dengue fever without hemorrhage and with the hemorrhage is there. The first presentation is undetected, is asymptomatic infection. The clinical features, headache. Here, that is very important one is the retroorbit pain and myalgia and arthralgia. Then dengue shock syndrome, criteria for dengue hemorrhagic fever plus evidence of circulatory failure. The rapid weak pulse, that is a hypotension, that is less than 20 mm Hg. It is narrow pulse pressure. The restlessness, food activities, delayed capillary refill, these are the classical presentation of dengue shock syndrome. It's an investigation is less than 1 lakh. The platelet count we are carefully, the care is your need for the case, but it will reduce below 50,000. Then patient need admission. I'm not going into details. Then homeopathic management, dengue fever, the common drug, we are using Epitorium, Rustox and Arsenicum. Then dengue hemorrhagic fever, we are considered Hamamelis, phosphorus and Quercus papaya. Then dengue shock syndrome, we were first considered Apis mellificum. Then general management, the monitor the level of consciousness in dengue fever. Then if we are needed IV fluid guided by the hematocrit value basis, we are recommended IV fluid, advice rest. In hemorrhagic fever, must IV fluid, check all the vital signs and regularly check the hematocrit value and urine output. That is very important. Then dengue shock syndrome, the bolus of 20 ml of kilogram by 0.9 saline solution should be given every 15 minutes. Then simultaneously advise the platelet therapy. That is apharetic platelet you are recommended. Then suppose very sudden fall in platelet count, apharetic platelet is just to advise. Okay, thank you. Because the remaining topic, the remaining conditions we are discussing in another day. Once again, I extend my sincere thanks to the organizers. Again and again, give me opportunity to present the topic or in our this particular platform. Thank you, sir.
Yes, thank you, Dr. Ajayan. Nice presentation. You presented 4 type of cases: dengue, hand foot mouth disease, then the monkeypox and scrub typhus. Each and every one is very important and interesting one, especially the last one. A lot of patients are affected with this dengue fever. Now often it become critical, and you just provided how to manage the case. The case protocol is also there. That type of this management is needed in homeopathy, definitely, especially when you are studying, teaching in a homeopathy medical college hospital. Dr. Tanesh, please.
Yes, the subject itself is a very important one, and as all of us know that Professor Dr. Ajayan has done a beautiful presentation in this season. because this is just only the monsoon arrived. This is the first time that we are able to make such a presentation in time. Usually we may present a little bit later, but even at the time of the same climate change, we are able to conduct such a session. And anyway, sir has been not able to present all the topic because it's a one hour session. Anyway, we will have to arrange. We will need to arrange the second part of the same as early as possible, as per convenience also. Just some 1 week back, we have very heavy summer, and some people were dying out of the summer stroke. But all of a sudden, the climate change, and now the medicines also change. Last time we used to give bryonia at the end of the session, but now bryonia as well as natron carb were the good remedies. But now it is changed to chili remedies. Am I right, Ajay sir?
Right, sir. It's right. Even the symptoms are changed. We are again and again change the medicines. Because in very beginning, I say the 3 levels of diagnosis very important for the selection of the medicine: the anatomical and pathophysiological, pathological and clinical diagnosis. All these 3 are right. That time only our medicines wonderfully acting in our human body. Not only in a symptomatological diagnosis, even we are correct the pathological diagnosis plus the anatomical diagnosis. Okay, thank you, sir.
Sir, which medicine you prefer for the season in the beginning? Whether
The now use for this gelsemium belladonna as an then antimonium crudum. The number of cases, even the last week, when corrected with the last 2 weeks, and corrected the antimonium crudum, bryonia antimonium crudum. Then again, belladonna. After the rainy season, okay, there are stocks, etc.
Okay, yes. Dr. Tanesh, could you please express a lot of thanks, Dr. Ajayan?
yes, sir. As we expected, another blistering performance from Ajay sir, and we are really thankful to sir, because I just only last day I called sir and confirmed the presentation, because there was another person for the day. Unfortunately, he felt ill, and then sir agreed to present the session, and that itself is a beauty of the presentation. Beauty of that itself shows the intense desire of Ajay sir and to homeopathy, and that's the reason whenever we call for such presentations, sir come over here and make such a brilliant presentation. Anyway, on behalf of International Forum for Promoting Homeopathy, as well as on my behalf, thanking you, sir, once again, and those who attend the session also need to be appreciated, and we can congratulate all of you for your excellent participation in the session.
Yes.
Thank you all.
Well, the IFPH platform proved that we have sufficient number of the efficient teachers. That's the most important thing and interesting on. The remarks that we conclude today's English edition. Hope you that will be back again tomorrow. Till then, goodbye, and Dr. Shaila to continue the program in Malayalam.